Docura is AI built to understand your documents. It runs locally so information never leaves your computer. Workspaces keep your case information isolated. Here's how I'd use it as a clinician, in this case for a morbidity and mortality review. This workspace contains admission reports, GP progress notes, cardiology consultation, medication history, laboratory trends, multidisciplinary review minutes, risk management guidelines, and event review framework. I've indexed the workspace so everything is now searchable and cross-referenceable by the AI. Let's review the case. Describe the patient's medical history and baseline cardiovascular risk factors. The patient is a 59-year-old male accountant with a history of type 2 diabetes, hypertension, dyslipidemia, and a BMI of 30. These include several risk factors that contribute to his cardiovascular disease. The patient has established atherosclerotic cardiovascular disease due to his history of hypertension and diabetes. He is at high risk for future cardiovascular events. Describe the events leading up to admission and the reason for admission. The patient had a history of uncontrolled LDL cholesterol despite medication adjustments. His LDL levels remained above target at various time points. The patient had poorly controlled hypertension and diabetes. We see that his blood pressure was consistently above target at various time points. Additionally, the patient experienced symptoms suggestive of angina, such as exertional chest discomfort. The final event leading up to admission was a non-ST elevation myocardial infarction, which occurred when the patient presented with chest pain at rest. Therefore, the reason for admission was the infarction, which may have been precipitated by the underlying cardiovascular risk factors and uncontrolled medical conditions. For each domain in the cardiovascular event review framework, identify the most defensible primary contributor and provide supporting evidence. For each domain in the cardiovascular event review framework, it's identified the most defensible primary contributor and provided supporting evidence. Domain 1, lipid management adequacy, suboptimal LDL control. Domain 2, blood pressure control, uncontrolled hypertension. Domain 3, glycemic control, poorly controlled diabetes. Domain 4, referral adherence, lack of timely referral. Domain 5, follow-up systems, inadequate follow-up. Domain 6, patient engagement, poor patient engagement. Supporting evidence, the most significant risk factor contributing to the cardiovascular event appears to be suboptimal LDL control, which is supported by multiple indicators. Elevated LDL levels despite medication adjustments, recommendation for intensified statin therapy and addition of ezetimibe, history of uncontrolled hypertension. Overall, while all domains contributed to the patient's risk, suboptimal LDL control appears to be the most critical factor leading to the event. Now we'll bring all of this together. Propose system-level safeguards that would have intercepted this case before the infarction. Specify trigger thresholds, responsible parties, and monitoring mechanisms. Following system-level safeguards can be implemented: trigger thresholds, responsible parties, monitoring mechanisms. It's also offered further proposed system-level safeguards: electronic health record integration, cardiovascular risk assessment tool, automated reminders and alerts, collaborative care models, patient education and engagement. By implementing these system-level safeguards, it's possible to intercept cases and reduce the risk of outcomes, improving patient care. This is what a clinical workspace might look like in Docura. I can reconstruct risk trajectory, review events against guidelines and frameworks, and interrogate system factors, all locally within an isolated workspace. That's how I'd use Docura in practice. To learn more or to start a free trial, visit docuraai.com.